right, well, hopefully you're seeing MRI Online case review, and I am Dave Yousem, and just a few disclosures as far as the books that I've published and my relationship with MRI Online. So we're going to start with the very first case, and hopefully you're seeing the screen. And the history on the first case from the electronic medical record says that this is a 64-year-old male with smoldering multiple myeloma and mantle cell lymphoma who underwent bone marrow transplant complicated by graft versus host disease and had CNS relapse of the mantle cell lymphoma. The patient presented with spelling and reading difficulties as well as a mild headache. So I'm showing here the only sequences that were performed on this patient because he had difficulty within the scanner. The initial scan here, that is motion artifact, obviously, is the flare scan. And you can see considerable motion artifact. But when we look at the analogous diffusion weighted scan, we see that actually he held still for this one. And there is this high signal intensity bilaterally in the central white matter of the centrum semiovale and corona radiata. And on the ADC map, you can see the low signal intensity associated with the bright signal intensity on the DWI. So DWI and ADC map. And the corresponding flare, which although there's a lot of motion artifact, it actually looked pretty reasonable. We weren't seeing a similar area of abnormality on the flare scan. So I'm going to go back to my slides here, hopefully. And we're going to take case one. And Ashley, could we have the first survey? Given the clinical history, what is the most likely diagnosis? Would this be A, posterior reversible encephalopathy syndrome, B, radiation therapy, C, CNS lymphoma, D, methotrexate toxicity, E, progressive multifocal leukoencephalopathy, or F, all of the above? So given the clinical history, what's the most likely diagnosis in this patient? PRES, radiation therapy, CNS lymphoma, methotrexate toxicity, PML, or all of the above, the most likely diagnosis. All right, the results. So 1/3 said radiation therapy, 1/3 said CNS lymphoma, and 1/3 said all of the above. Very good. So this is another example of the same entity. In this case, you see that the flare signal abnormality is quite apparent, but the diffusion weighted scan is negative, as opposed to our case where the diffusion was positive and the flare was negative. So this is indeed methotrexate-induced leukoencephalopathy, which has this interesting phenomenon. In fact, let's go to the next question, Ashley. What is the unique MR feature of methotrexate toxicity? Is it DWI positive, flare positive, but gadolinium enhancement negative? Is it DWI positive, flare negative, but GAD negative? Is it DWI positive, flare negative, GAD positive? DWI negative, flare negative, and does not enhance on GAD, or none of the above? What is a unique MR feature of methotrexate toxicity? So people are putting DWI positive, flare negative, GAD negative. So indeed, just as in this case on the slides, you see that the DWI is positive with reduction in ADC. It's actually a bilateral process, but the flare is basically negative. There may be a little bit of bright signal, but that was not even present on our current study. While this is not exclusive, while methotrexate toxicity can look in a lot of different ways, this is one of the ways it can look that is relatively pathognomonic. So I want to talk a little bit about iatrogenic causes of neurologic decline, because this methotrexate-induced leukoencephalopathy was the source of this patient's reading and difficulties and headache. So here's another example of a patient who has graft versus host disease, had pseudomembranous colitis, and then developed mental status changes. And the findings here are the bright signal intensity bilaterally in the dentate nucleus, as well as in the brainstem and middle cerebellar peduncles, as well as you can see, abnormal signal intensity in the splenium of the corpus callosum. And this was an example of metronidazole toxicity. So another one with MET, but not methotrexate, but metronidazole or flagyl toxicity, which can lead to the peripheral neuropathy, ataxia, etc. And usually you have abnormal signal in the deep nuclei of the cerebellum, in the periaqueductal gray, and in the splenium. And this also may be DWI positive, but it doesn't show contrast enhancement. Here is an example, a few examples of PRESS, posterior reversible encephalopathy syndrome. As you can see, the abnormal signal intensity in the occipital lobes and parietal lobes. Some cases is a separate case where it was quite diffuse bilaterally, also involved the brainstem. Then the third case where you see the abnormal signal in the parietal lobe going out to the peripheral white matter, but not affecting the gray matter. And there is a little bit of contrast enhancement, which is atypical for PRESS. Usually only 10% of cases show enhancement and only 10% show hemorrhage. So PRESS is mediated through hypertension, but it also may be due to various medications that we give, and therefore it's in the iatrogenic category because of the possibility of the reaction to cyclosporin or tacrolimus or any of the various chemotherapy agents. Here's one, again, where it may be iatrogenic. You have osmotic demyelination or central pontine myelinolysis with sparing, in this case, of the corticospinal tracts. In this case, a separate case, it involves the corticospinal tracts and shows restricted diffusion. So this is osmotic demyelination secondary to overly rapid correction of hyponatremia. Again, an iatrogenic cause because we, the physicians, have corrected the hyponatremia, the low sodium, too rapidly. Here's one that's maybe not quite iatrogenic, but self-induced, opiate-induced leukoencephalopathy, where you have all this bright signal intensity, both in the posterior fossa white matter as well as bilaterally in the temporal lobes. This is from a patient who was doing intranasal smoking of heroin, snorting. Another cause of abnormal signal intensity and neurologic decline is the institution and the withdrawal of epilepsy drugs, most commonly seen in Keppra. Here you see abnormal signal intensity in the splenium of the corpus callosum, which is highlighted here. And again, this is a cause of neurologic decline, of cognitive decline. It may be due to the institution of the medication for seizures or when it's withdrawn. So you have to be careful about that. So this splenial lesion is may be associated with Tegretol use or withdrawal of those antiepileptic drugs. In this case, again, focal area in the splenium. This is another example that is related to methotrexate, and this is Fludara. Fludara is a medication that's used for the treatment of leukemia and lymphoma, sort of like methotrexate, but not the same drug. And this one also, as you can see, affecting the splenium and the genu of the corpus callosum, as well as the central white matter. And this is an entity called acute toxic leukoencephalopathy, which was reviewed in February 2019 AJNR. And you can see the change in mental status is typical. This is readily reversible like methotrexate leukoencephalopathy. And it may be diffusion positive, but flare negative, like methotrexate. And here's just some of the list of the drugs that can cause toxic leukoencephalopathy. You have the fludarabine or Fludara, methotrexate, other medications, opiates, heroin, etc. And this is from that article in February 2019. So with that, let's move on to case number 2. Okay, so case number 2, the history here was a patient who had discoloration in the left buttock and left leg associated with left foot spasms, and he developed chronic perineal numbness and urinary incontinence. And after prolonged sitting, his legs felt like cement, and they felt like his legs were dissociated from his body. So that's interesting history. Here is the T2 weighted image. I'm going to see if I can blow that up. There we go. The T2 weighted image where you see multiple lesions on the T2 weighted scan. Let's see how it looks on T1 weighted. So here it is on T1 weighted. Let me just window that a little bit better. There we go. Some areas of bright signal intensity. And then on the post-gadolinium enhanced scan, you see it again. And let me try and get these all together so we can see how it looks. So the T1, post-GAD T1, and the T2 weighted scan. Okay, so this is case number 2. And Ashley, can we have the polling? Okay, that's what's the most likely diagnosis. Is this multiple hemangioblastomas of the spine leading to the diagnosis of von Hippel-Lindau disease? Is this multiple cavernomas? Is it a spinal dural vascular malformation? Is it Klippel-Trenaunay-Weber syndrome? Is it Wiskott-Aldrich syndrome, or none of the above? So what's the most likely diagnosis? So 67% went with multiple cavernomas. Then we have the other, none of the above, and Klippel-Trenaunay-Weber. So this patient actually did have congenital keratoangiomatosis, but these lesions were characteristic of multiple cavernomas. So let's take a look. So here's the T1, the T2, and the post-GAD T1. And characteristic of cavernomas is this hemosiderin ring around the lesions. And you can see some of them are purely dark on T2, although bright on T1, so likely in a methemoglobin phase. Here it is on the axial scan. You see abnormal signal in the spinal cord that's dark with no real cord edema. So next question. What is the most common spinal vascular malformation listed? Is it a spinal dural AV fistula? Is it a spinal intramedullary AVM? Is it spinal extramedullary AVM? Is it a spinal extramedullary intradural arteriovenous fistula? Or is it none of the above? What is the most common spinal vascular malformation of those listed? Is it a dural AVF, an intramedullary AVM, an extramedullary AVM, or an extramedullary but intradural arteriovenous fistula? And we'll check the answers, and the correct answer is indeed a dural AV fistula. So if we can go back and look at our slides here, this was multiple cavernomas, which have the characteristic hemosiderin ring around them with absence of edema in the spinal cord. There's really very little expansion other than of the actual cavernoma itself. They may show faint enhancement. Angiography is negative, and these represent 12% of all spinal vascular malformations. So it's probably number 2 behind the spinal dural AVF. Here another example of a cavernoma of the spinal cord, dark in signal intensity from the hemosiderin and no significant mass effect. So of the vascular malformations, the most common is indeed the dural AV fistula. And the dural AV fistula may present with lower extremity weakness or sensory loss. It's typically seen in older men, I guess not so old anymore, but men in their 5th or 6th decade. And it's a progressive subacute presentation with lower extremity weakness and ultimately some element of potentially the urinary incontinence. What we see for dural AV fistulas is the enlarged veins, typically on the posterior aspect of the thoracolumbar junction, associated with abnormal signal intensity within the spinal cord, which is thought to be secondary to the venous congestion from the AV fistula. Here's a different patient with a little bit more dramatic signal voids on T2 scan from the arteriovenous fistula venous drainage. These usually will show very little, if any, enhancement. So just to make sure you understand what the pathophysiology here is, this is from Spetzler's article in 1989, one of his illustrations. And what you see is this fistula between the artery and the veins. These are the veins on the surface of the spinal cord. This is actually in the dural sleeve of the nerve root typically, and therefore is considered extradural, even though we call it a dural AV fistula. Or some people would call it peridural. And there is this artery to vein connection, and it leads to the big veins and the venous congestion in the spinal cord. Type 2 is, and type 3 are vascular malformations where you have a lesion within the spinal cord. This is called the juvenile metameric form, where it also extends out into the adjacent soft tissues that are extradural. But type 2 is purely intradural intramedullary arteriovenous malformation, not a fistula, but an actual nidus within the spinal cord. When it spreads throughout this segmental level, we call it the metameric variety, or type 3. And finally, we have type 4, which is a fistula, which is intradural but extramedullary. So not in the nerve root sleeve, but actually within the thecal sac, and that's the type 4 AV fistula. And this is an example of one where there was that connection in the flow void within the thecal sac. This was not spinal hemangioblastoma. When you see spinal hemangioblastomas, we remember the 1/3 rule, and that is that 1/3 of patients with spinal hemangioblastomas have von Hippel-Lindau disease, and 1/3 of patients with von Hippel-Lindau disease will have a spinal hemangioblastoma. They usually don't show the hemorrhage like the cavernomas. Here's a nice example of T2, pre-GAD T1, and post-GAD T1 with the cyst and nodule of a hemangioblastoma from von Hippel-Lindau disease. And here's another example of one with multiple, in this case, cyst and enhancing nodule, as well as enhancing nodules on the nerve roots. So von Hippel-Lindau disease. Let's move on from here and go to case 3. So the history here is, this is a 50-year-old woman who had allergies and sinus congestion that was longstanding. She started to develop some bleeding from the left nostril, and she complains of pressure in the left nostril, but not pain. She's been having headaches. All right, so on the T1 weighted pre-gadolinium scan, we see area of high signal intensity in the left nasal cavity. On the T2 weighted scan, you have dark signal intensity. You have within the left maxillary antrum and ethmoid air cells and frontal sinuses areas of high signal intensity. And when we give gadolinium, we notice that this lesion, I'm not sure whether it enhances given how bright it was on the pre-GAD, and the sinuses in the maxillary antrum and ethmoid and frontal sinuses are not showing enhancement. And again, here's that same lesion. Let's see if I have a better looking T1 pre-GAD. No. So, well, we can go with this. So pre-GAD, here's the lesion. So Ashley, while I go to PowerPoint, can you give them the first question on this case? What's the most likely diagnosis? Is this most likely squamous cell carcinoma, adenoid cystic carcinoma, inverted papilloma, a chondroid tumor, or none of the above? So the most likely diagnosis in this case is it squamous cell carcinoma, adenoid cystic carcinoma, inverted papilloma, a chondroid tumor, or none of the above. So none of the above got the most common. So you guys are thinking well here. How about the next question? What is the unique characteristic feature of a sinonasal melanoma? Is it bright on T1, bright on DWI, bright on CIS, bright on GAD, none of the above, or all of the above? So bright on T1 is the correct answer. And in point of fact, this was indeed a sinonasal melanoma. I suspect that the people who said none of the above were concerned about that. When you have this bright lesion in the sinonasal cavity and it is not within the sinus as secretions, you have to worry about either a hemorrhagic lesion or a melanin-containing lesion. In this case, as you can see with the T2 weighted image, this was a lesion that was dark on T2 and bright on T1, which is characteristic of melanin. It might also be an element of hemorrhage. And the lesion may be showing some contrast enhancement. Because it's bright on T1, it's kind of hard to sometimes tell that this was, whether it's enhancing. You notice that the sinus secretions are just obstructed secretions. There's no enhancement. It's got the typical rim of enhancement of the mucosa. And therefore, even in the ethmoid sinus, we see that this is not enhancing tumor. So this signal intensity could be secondary to secretions, and we'll pursue that in just a moment. Here was a CT scan on the same patient, so this was not subtle. This lesion was growing into the nares on the left side, and you can see on the CT scan, no real hemorrhage. This was bright on T1 because of the melanin, not because of the hemorrhage. This was a CT taken the same day. And here's the obstructed secretions. So just a word about the signal intensity of secretions. This was great work that was done by Peter Somm, actually, in the late 1980s, early 1990s. And what he did was he aspirated the secretions of patients who had various signal intensity on the MRI scan, and then got the protein concentration of those secretions. And what he found was that initially, when the secretions are like fluid, it's obviously going to be dark on T1 and bright on T2. And then as the protein content increased in the secretions, it crosses the iso-intense bar and starts to become bright on T1 as well as bright on T2. And then there is a time when the T2 signal is falling, but the T1 signal remains bright. And this is at like a protein concentration of 30%, where it's bright on T1, dark on T2. And then as it gets more and more desiccated, both dark on T1 and dark on T2. So initially you have to make sure it's not sinus secretions. Let's just take a quick look at some examples of sinus secretions. So this is, none of these are with GAD. I'm sorry, this is with GAD, but here we have T2 and T1, bright signal intensity within the sinus, dark on T2. Here it's bright with a little darker area. Here it's bright on the periphery and darker centrally. All of these are inspissated secretions. We might also worry when we have bright on T1 about fungal infections, but most of the time, this is secondary to inspissated chronic secretions. And you can see that with contrast, it will remain peripheral enhancement just along the mucosa rather than centrally, which one might expect with a patient who had melanoma. So let's, the typical time that we see bright signal intensity in the sinuses is either with chronic sinusitis, or the other option is with mucoceles, where you have an obstruction of the ostium. And in this case, here's the mucocele on CT. Here's a different one on MRI, where you can see that the secretions are bright on T1 and intermediate on T2. These were inspissated secretions. How do we know that this is not a melanoma? Well, again, you get the post-GAD and you'll see the peripheral enhancement, but it may be that you need to get the CT scan to demonstrate that as well, because that's in the differential diagnosis. Here is a patient who has an inverted papilloma. And inverted papilloma is one of the benign tumors of the sinonasal cavity. It has this cerebriform appearance where it almost looks like there's gyral forms within like the brain in the signal intensity on T2 weighted scan. And these will show solid contrast enhancement. Remember that there's a 10 to 15% rate of squamous cell carcinoma in a inverted papilloma. Here's a patient who also presented with nosebleeds like our patient, but this was a young adolescent man, and you see multiple flow voids within this lesion. You can see them on as the bright signal intensity here. This was a patient who had a juvenile angiofibroma. Here's a patient who had a chondroid lesion, and remember that chondroid lesions sometimes will be bright on T1 weighted scan by virtue of the calcification. And this one was quite large. They're typically in the midline because they arise from the cartilage of the nasal septum in most cases, or off of the perpendicular plate of the nasal septum. And they may have this bizarre kind of popcorn look, both on gadolinium as well as on the CT scan. And this is a different one, another patient with a chondroid lesion. Of the malignancies in the sinuses, the vast majority are squamous cell carcinomas, and the vast majority occur in the maxillary antrum, presenting with erosion of the bone and with a prior history of chronic sinusitis. They may show perineural spread into the second division of the fifth cranial nerve and rarely have nodal metastases. So this is an example of a patient who has a midline squamous cell carcinoma, which grew into the orbit, was still confined by the periorbita here, and therefore they did not have to do an orbital exenteration. Other sinus malignancies include minor salivary gland tumors, where you may see perineural invasion if it's adenoid cystic carcinoma. In woodworkers, we worried about adenocarcinoma. And then there are some nasty ones, the sinonasal undifferentiated carcinoma and lymphoma. And SNUC, or sinonasal undifferentiated carcinoma, is a very fast-growing tumor. It usually erodes things pretty aggressively and is poor prognosis. And then finally, we have the other ones. Again, melanoma is not a large component of the sinus malignancies, but it does have its characteristics, signal intensity features. Here's another melanoma and a third melanoma here in the sinonasal cavities. And one thing to remind you is that some of the metastases to the sinonasal cavity may be hemorrhagic and therefore be bright on T1 based on the hemorrhage. And those include the kidney, and melanoma from the periphery may be metastatic to the sinonasal cavity. This was a patient who had bright signal intensity. This was a kidney carcinoma metastasis to the sinonasal cavity that had hemorrhagic metastasis, and the bright signal was not due to melanin, but due to the hemorrhage. So let's move to our next case. So this was a patient, let me get the history here. 47-year-old woman with hypertension, chronic iron deficiency, anemia, tobacco use, obesity, hyperlipidemia, who presented to the ED with aphasia. She was found at 7 a.m. by the family sitting outside her house, nonverbal, looking confused. Her car was missing. So I'm going to show this to you, and here is the initial CT scan, and this is without contrast, and we can see an area of low density in the frontoapicular region just above the Sylvian fissure here. And what I'd like to pull up is our perfusion imaging. This is the cerebral blood flow image. This is the cerebral blood volume image. Let me go to see what I can get to 4-on-1 here. 2x2. Okay. Let me go back and show the initial CT. And then I want to show the Tmax, which I hope is this one. Okay. So this is the cerebral blood flow. This is the cerebral blood volume. This is the CT, obviously without contrast. This is the Tmax. And we do use rapid analysis. And let me see whether I can pull up the rapid analysis. Not sure where this is going to be it. Okay. This is the Tmax on the rapid analysis. This is CBV on the rapid analysis. So we have both the Siemens Singo analysis as well as the rapid analysis. So let's go with the first question. Let me hear, this might be what I'm looking for. So this is the rapid analysis. You have the Tmax analysis. You have the CBF analysis, and then you have the mismatch volume analysis. So let's go with the first question, Ashley. Which perfusion sequence is most useful to identify the completed stroke? Is that CBF, CBV, mean transit time, Tmax, time to peak, all of the above, or none of the above? So the perfusion sequence that's most useful for identifying a completed stroke, not necessarily in this case, but in in general. So 38% said CBF, 25% CBV, and some said all of the above. So we'll discuss this, but most people are adopting CBF. As you can see here, the CBF on the slide did show the infarct here, whereas the CBV maybe here, it's not quite the same slice, but was not as dramatic. Okay, and let's go with the next slide. Is there tissue at risk in this case? So looking at the sequences that are on the screen, is there tissue at risk in this case? So 63% said yes, and 38% said no. And I think we have one more question on this one. What are the typical rapid analysis parameters used by neurology? So we had a lot of different parameters here that we were evaluating, and which of these is the ones that have been accepted by neurology? Is it CBF less than 30%, Tmax less than 6 seconds, CBF greater than 30%, Tmax less than 6 seconds, CBF less than 30%, Tmax greater than 6 seconds, CBF greater than 30%, Tmax greater than 6 seconds, or none of the above? And indeed, the correct answer is C. So let's look at this case. So here we have the area of infarction seen on the CBF. And when we compare that to the Tmax 6-second evaluation, I would say that there is a larger area of abnormality on the Tmax 6-second than there is at the CBF less than 30%. And therefore, there is tissue at risk. And this is verified on the rapid analysis, which you see that it said that the CBF volume less than 30% was 4 cc's, but the Tmax volume of greater than 6 seconds was 6 cc's. So the mismatch volume was 2 and the mismatch ratio was 1.5. So there is tissue at risk in this individual. And this is pretty much how we analyze our strokes currently at Johns Hopkins. We report the rapid values. So let me just go back to here. This patient had on the CTA, I didn't show this, a focal area where there was absence of enhancement on the CTA within the middle cerebral artery beyond the bifurcation. So this was a peripheral branch that was at sort of the M2, M3 junction where there was absence of enhancement within the blood vessel, so a focal clot, which was accounting for this stroke. We do not do aspects score at Johns Hopkins. However, that has become sort of the norm. And the aspect score, you subtract whatever area of infarction is as labeled by the different locations here and subtract that from 10. So I would have said, based on this appearance on the CT, that that was affecting both the M1 and M2 areas. And therefore, my aspect score would be an 8. Aspect standing for Alberta Stroke Program Early CT score. And the aspect score is another area, another potential place where you can have prognosis. So here were the, using the SINGO, showing that the Tmax area was larger than the area of CBF loss. And this can lead to a calculation of the PRR, potential recuperation ratio, which you sometimes will see. Here, on the other hand, it was the Tmax evaluation with the mismatch ratio of 1.5. So 2-month follow-up on the same patient. This is the area of infarction, and you can see that it looks pretty similar to the area of abnormality in the CBF. And in this area at risk, the tissue at risk, was not all infarcted on the follow-up MRI scan. And so that area was able to be saved with medical management. So just to refresh your memory, the American Heart Association, American Stroke Association, 2018, suggested that using perfusion imaging is recommended for patients who present within 6 to 24 hours of large vessel occlusion, and it may help identify those patients who will benefit from mechanical thrombectomy. So you're seeing a lot more CT perfusion on that basis. And the analysis packages that are available will offer you the different parameters, in this case, Tmax 10 seconds, 8 seconds, 6 seconds, and 4 seconds. You can see that depending upon where they are, the volume of tissue at risk on the perfusion portion may be quite variable. Similarly, with the CBF of less than 30% and the Tmax of 6 seconds, you can just parse it down to what the neurologists are currently using and create this mismatch volume and mismatch ratio. And depending upon these parameters, they may or may not pursue more aggressive thrombectomy. I'm going to skip a little bit about the CBF in the interest of showing more cases, but suffice it to say that CBF has been adopted as the best in showing the infarction. CBV, the problem with it is that initially you may have this vascular dilatation, which leads to increase in the CBV in the patient. So you see it actually increases over the course of time and then will drop off precipitously, whereas CBF shows that decline that's a little bit more linear in its development. And just again, a reminder about the aspect score. So let's move on and finish with case 5. So here we have a mass, and let me get you the history from the chart. Says this is a patient who developed right-sided lower leg weakness and numbness and pain. So numbness and pain. So here we have the T2, the T1 pre-contrast, the T1 post-contrast, and I'll bring down the T1 axial post-contrast to show you what the lesion looked like. All right, so based on these images, Ashley, can we have the first slide? What is your favorite diagnosis? You think this is most likely a chordoma, a giant cell tumor, an ependymoma, a schwannoma, a meningioma, or none of the above? What is your favorite diagnosis for this lesion down here? This is, I guess, at S3. So most people are going with chordoma and one person with schwannoma. Let's take the next slide. Can ependymomas be extramedullary in the spine? So usually we think of ependymomas as intradural, intramedullary, but can the ependymoma be extramedullary in the spine? And 100% said yes. Okay, so let me go to the sides and try to close out this case. So I thought this was going to be an ependymoma because ependymoma, here's the lesion, here's the T1, T2, and the axial T1. I thought this was going to be an ependymoma of the phylum terminale, which is one of the varieties of ependymomas, which is the myxopapillary ependymoma. And that is one of the sources of sacral masses. Most commonly, we see chordomas, and usually in adults, teratomas in kids. You can have giant cell tumors and plasmacytomas, which frequent the sacral region as well. It could be a metastasis. The ependymoma is the myxopapillary variety. These are intradural but extramedullary, and everyone said 100% said that they can be extramedullary. It's true, they can be outside the spinal cord, down here in the sacral region. That's why I kind of went with it, because it was kind of heterogeneous in its signal intensity, had some cystic areas, but I was wrong. Here's an example of an ependymoma, heterogeneous in signal intensity at the phylum terminale, myxopapillary variety. Here's another example where you can see it eroding the sacrum, and that can occur with ependymomas. This looked very much like the one we saw. However, the one we saw ended up being a schwannoma. So congratulations to the one person who chose schwannoma. Of the nerve sheath tumors, schwannomas are more common than neurofibromas, but neurofibromas are the ones that can have malignant degeneration. And here's a patient who has neurofibromatosis type 1 with multiple neurofibromas and schwannomas. You can see them coming out. Has the target sign of the dark signal intensity center and the bright signal intensity periphery. And that might suggest a neurofibroma as opposed to a schwannoma. But this lesion ended up being, on resection, a schwannoma that was just probably in the sacral region, one of the nerve roots. I'm just going to show you that one of the features, I wondered where this was too large right here on this case, that maybe the patient actually does have multiple schwannomas because this nerve root seemed disproportionately enlarged. I passed through that. You can see that it shows enhancement. So I wonder in retrospect whether I missed it and that the patient actually had multiple schwannomas or neurofibromas. So I think we'll probably, let me see, let me go to the PowerPoint and just demonstrate one more case so that way. This is case 6. It was a patient who had multiple nodules as well as calcifications in the parotid gland. You see this kind of acinar pattern in the parotid gland with, you know, what looks like glandular tissue as well as these focal nodules. And here's focal nodules. This patient it has calcifications that are not stones in the ductal system, but calcifications of the parotid gland itself. And here's another example with cysts and nodules as well as calcifications. This pattern is has a differential diagnosis. The most common thing is going to be Sjogren's disease. It can occur with HIV and benign lymphoepithelial lesions, as well as other collagen vascular disease, including lupus. Here's another example with multiple nodules and cysts in the gland. And so the parotid gland calcifications include a differential which includes Sjogren's most commonly, but chronic kidney disease with calcium phosphorus dysmetabolism, HIV, lupus, mixed connective tissue diseases, some neoplasms which can have calcification. This ended up being a patient who had both lupus as well as sarcoidosis, same patient, multiple glandular calcifications, not sialoliths in the ductal system. So that was another case. So why don't we go with the questions and we'll see about the answers. Okay, so I assume that this is asking about the cavernomas of the spinal cord. In this case, that is methemoglobin. Remember that methemoglobin on T1 is bright in signal intensity. However, depending upon whether it is extracellular or intracellular, it may be dark or bright on T2. So intracellular methemoglobin is bright on T1, but dark on T2, because you have effectively a bar magnet effect of the concentrated iron of the methemoglobin within the cell, outlined by the cell membrane. So therefore, as water molecules go past, it gets dephased by a magnet inside the cell. However, when we have extracellular methemoglobin, it's bright on T1 and bright on T2. And the reason for that is because you've had cellular lysis, and now that hemoglobin is able to diffuse through the intracellular as well as extracellular compartment, and therefore all you're seeing is bright in signal intensity, not a localized magnet effect by intracellular methemoglobin. So can slow flow be bright? Yes, absolutely. But in cavernomas, it's usually not slow flow that is causing the bright signal, but methemoglobin. Cavernomas, by and large, though, are characterized by the presence of hemosiderin, which, as we know, is super paramagnetic. It's got this super bar magnet effect, and therefore causes marked reduction in the T2 signal, causes T2 shortening, which leads to dark signal in T2. And that's pretty much, that's the sine qua non of a cavernoma, a peripheral rim of hemosiderin. With regard to the melanoma case, that also may be bright on T1, but the brightness on T1 is due to the melanin itself, or in those patients who have amelanotic melanoma, you can still have hemorrhage. Melanomas are hemorrhagic lesions, and therefore the bright signal intensity in a melanoma may either be from the melanin itself or from hemorrhage in a melanotic melanoma, or hemorrhage in one that is an amelanotic melanoma. And when we say amelanotic melanoma, we're talking about the degree to which there is melanin within the lesion. So that's usually bright on T1. In the sinuses, bright on T1 may be due to the high protein. So we go back to Peter Som's diagram. So you see bright on T1 on the basis of high protein concentration at that 20 to 30% range, where it's bright on T1 and it may be either bright or dark on T2, depending upon how high the protein concentration is. The final thing that we say may lead to bright signal intensity on T1 is things like cholesterol accumulation. So the cholesterol granuloma, while most of the time it's due to hemorrhage within it, that leads to the bright signal in T1. Occasionally you can have the cholesterol crystals in the macrophages with the foreign body reaction that in and of itself may be bright on T1. So high protein, melanin, hemorrhage, and sort of the cholesterol-laden crystals, bright on T1. We are doing DTI sequences, but we're not processing them with tractography or anything. We're using the DTI sequence just to get a better looking DWI or ADC map. The reason why this question was asked is because diffusion weighted imaging is actually quite sensitive for the cytotoxic edema of diffuse axonal injury. And so that is a pulse sequence that we use, and we do it with DTI, but we're not creating maps, and we are actually not doing it quantitatively. We're just looking at it qualitatively to look for areas of shearing injuries. And the most common place that you would find that is at the gray-white interface, as well as in the splenium of the corpus callosum, which is another characteristic location where you may see a shearing injury of the white matter in diffuse axonal injury or traumatic brain injury. The most important sequence, I would say, however, is not the DTI, but the SWI. So with susceptibility weighted imaging, we see a lot of petechial hemorrhages, microhemorrhages associated with the diffuse axonal injury. What we used to think of as non-hemorrhagic shearing injuries have been demonstrated with SWI as actually having hemorrhage associated with it, with the SWI, little microhemorrhages at gray-white junction, in the basal ganglia, at the midbrain, and in the splenium and corpus callosum. You'll see those little dark areas from the SWI from the hemorrhage. So we rely mostly on the SWI, then obviously we'll have the DWI/DTI and the flare scans as the mainstay for demonstrating diffuse axonal injury and traumatic brain injury on MR. Okay, well, if we don't see one, then I'll go in and show another case if we have in the last 5 minutes. Just interrupt me if there comes in a question, Ashley, and in the meantime, I'll show another case. This patient presented beta thalassemia and obesity, presented with acute sensory loss in the perineum and legs, had problems urinary, could feel the urge to go, but only trickle would come out, developed numbness and tingling over her perineum. So T2 weighted scan looked pretty much unremarkable. This is the post-gadolinium enhanced scan, where you see that there are areas of contrast enhancement on the surface of the spinal cord, as well as in the cauda equina nerve roots. So these did not look like vascular flow voids. We didn't see them on the T2 weighted scan as vascular flow voids, but looked like contrast enhancement that was on the surface of the spinal cord and in the cauda equina nerve roots. So this leads to a differential diagnosis of superficial enhancement of the spinal cord as well as the nerve roots. And there are a lot of different causes of nerve root involvement, including infections. When we think of infections, we think about all these different viral infections. You can have some tuberculosis, bacterial infections, fungal infections. This was cryptococcus with marked thickening and enhancement of the nerve roots. And the other option would be something like an autoimmune phenomenon, which is most commonly seen as Guillain-Barré, where the patient has motor weaknesses. Differential diagnosis, make sure that it isn't showing contrast enhancement. It's not Pantopeg, which is a fat-containing contrast dye. Or you may see subarachnoid seeding from a neoplastic etiology. Here's an example of Guillain-Barré. In this case, this diffuse enhancement of the nerve roots of the cauda equina. However, it may be isolated to the anterior, more motor nerve roots. When you see that favoring the anterior motor nerve roots, we go more commonly with Guillain-Barré. And this is sometimes also known as acute demyelinating polyneuropathy with the diffuse nerve root enhancement. Can be seen with after Campylobacter infections, GI infections, but any basic, it's sort of almost like a delayed type hypersensitivity reaction to the nerve roots. So after any viral infection, you may see Guillain-Barré. And in this case, although the patient had beta thalassemia, obesity, etc., the final diagnosis was sarcoidosis. So again, it is one of the causes of superficial enhancement on the spinal cord and nerve root enhancement. It may also be intramedullary. So this is an example of sarcoidosis in the spinal cord, not intradural extramedullary like the case I just presented, but intradural intramedullary with solid enhancement. It may grow in from the periphery on the surface of the spinal cord and then involve the cord. Here's another example, a different patient with sarcoidosis showing this coating of the conus medullaris and diffuse involvement of the cauda equina nerve root. So another consideration is sarcoidosis when you see superficial cord enhancement, solid cord enhancement, as well as nerve root enhancement, sarcoidosis. Check the chest x-ray. All right, be safe and healthy out there. Thank you.